I'm Dr. Shah with 360 Urology. I'm here today to talk to you about Peyronie's disease. Now, 360 Urology is located in Stockbridge, Georgia. It's about 15 minutes from the airport. The Atlanta airport is about 15 minutes from the city. So we're very conveniently located. We'd love to see you, hear from you. If there's something that piques your interest and you want to talk more about it, let us know. You can learn more about us at www.360urologyatlanta.com. All right, so today's topic is Peyronie's disease. It's a very underappreciated topic. It's a topic that typically gets swept under the rug, and patients and even providers are often unaware that there are treatment options for it. So what is Peyronie's disease or penile curvature disease? Penile curvature or Peyronie's disease is typically a secondary development of a penile curve. Oftentimes you can see it presents without a curve. It can present with a lump or indentation. And when you get a lump or indentation, sometimes you can sort of get a narrowing at an area of scar. Other times, if the scar is only on one side, the area where the penis gets erect and stretches, the area where the scar is, that can't stretch. So when this side stretches more than this side, it starts pushing the penis over and he starts noticing a curve. Typically, the worst point of plaque is going to be the point of max curvature. And those are some of the things that we mark and look for. But that, in essence, is Peyronie's disease. How do you get Peyronie's disease? It's very often times associated with erectile dysfunction. The most common reason is a patient trying to have sex. They're penetrating with semi-erect or partially flaccid penis. They're trying to penetrate, instead they sort of buckle or hit the side wall or the pelvic wall, and they traumatize the penis. They may not realize that it could be as severe as a penile fracture, which is a break in this erectile body, but you may not notice much from it. But on top of that, because you're already getting some poor blood flow into the penis because of the erectile dysfunction, the healing cells can't get there to this area fast enough, and instead of healing that tissue, it scars that tissue, and this tissue forms a plaque. And when you form that plaque, as it progresses, you can start getting Peyronie's disease. Typically, when you get Peyronie's disease, you start off in an active phase, right? So an active phase means that plaque is still evolving, it's still changing, and so during the active phase, we try to give you treatments like Cialis, pentoxifylline, and these are treatments that will try to make it so that more blood can get to that area while it's still changing and healing, to try to get it to a stable phase. And so what we're trying to do is stabilize the plaque, but while we're stabilizing the plaque and getting more blood to it to get it to heal faster, we also want to use things like a vacuum erection device, a VED, or a traction device. Now, our favorite traction device is a device called a Restore X device. You can get it from restorex.com, and it's a device that allows you to bend the penis in the opposite direction when you don't have an erection. It can kind of stretch that plaque and bend it at the same time, and it does have a lot of supportive data. There's been a ton of studies. It's developed by the Mayo Clinic and Landon Trust. It's a great device to use and can possibly reverse some of the Peyronie's before it ever solidifies, right? A vacuum erection device can stretch and engorge that channel, try to keep you from losing penile length, reverse some of that, and also straighten out the penis. So those are great options. I'd love to talk to you more about those. The majority of people will eventually get into a stable phase. Now, once you get a stable phase, how do you know when you're in a stable phase? Well, in an active phase, you tend to have some penile pain at that site of the plaque when you have an erection. Some patients don't have pain, but they still have a changing curve or a changing indentation. Once it's stabilized for 6 months, there's no more penile pain, and it's unchanged for 6 months, that's when we say, okay, now you're in the stable phase of Peyronie's. And that's when we start talking about treatments. Now, when we talk about treatments, again, you can do conservative measures, but in the stable phase, 90% of the time that's not going to work. You can still try traction devices and vacuums and such. If you're going to try, again, a Restore X, maybe some Cialis is probably the best way to do it, but there's a lower probability of it working. Usually at this point, it's going to be a procedural treatment. The procedures, the most common treatment that we do is something called Xiaflex. There are some other options like verapamil that are not as effective. Xiaflex is an in-office injection that has the best supportive data. It is pricey, so we do want your insurance to cover it. Excuse me. And it involves putting a needle into the scar tissue and injecting a collagenase. And collagenase means a substance that breaks down collagen. It's a substance that will, in essence, soften that scar. It does not make it go away. I wish it did. But it softens the scar temporarily, and then you can mold the penis using either a traction device, vacuum, or manual molding with your finger. And we can teach you how to do that. But when you mold the penis, you do it for about 4 weeks. We reevaluate things and then potentially start things again. You typically, most people, if you're going to do XIAFLEX, they're almost committing to 4 cycles of XIAFLEX. What does that mean? One cycle is an injection, then within 72 hours, another injection, and then molding for 4 weeks. Really, and then no sex for that 4 weeks period. So just keep that in mind. Then you wait about a week or 2 and you start this process all over again. So that 6-week period is a cycle. And so you do that 4 times. So keep in mind it's 6, 12, 18, 24. So 24 weeks to get you hopefully better. And there are varying results. Success rates are anywhere from 30% to 80%, depending on who's doing them, technique, plaque type, if the plaque is visible. So there are a lot of factors to take into account, and we talk about that. Patients that are not good candidates are patients that don't have a visible plaque or palpable plaque. So, well, if we have trouble getting this medicine inside a plaque, there's not much value to it. So, or patients that have too dense of a plaque, it's just so hard and so dense, it's just injecting it is just not going to do anything. Patients that have too much of a curvature or not enough of a curvature are those can also dictate whether it's worth or you can do XIAFLEX. And so these are things that we would talk about. Other options, any options after that are really going to be surgical. And when we talk about surgery, a quick fix is application. Application means this side here is essentially shortened because it cannot stretch. So what we do is we put stitches to shorten the other side and sort of even things out. And we do it with you either asleep or numbed up so that you don't feel anything. It's a quick fix. It takes about 15 minutes to do. You can do it in office. You can do it in the hospital. What are the downsides of application? The number one downside that people worry about is loss in length. So because we are technically shortening the penis, you are losing length. Now, so one thought is, hey, you're only as long as your shortest side, in which case you're not really truly losing length, you're just evening length. Another thought is, hey, you're only as short as your longer side, in which case you are losing length. And so it's just something that you should know. Most patients will lose between a centimeter to a centimeter in length, sometimes a little bit more, depending on how much of a curve we're trying to correct. And so that's something worth talking about. There is a rare risk of chronic pain, which is as irritation or inflammation from the stitches themselves. And then the third risk that we sometimes see is reversal, or a reversal back to your original state, or a residual curve, because we try not to overcorrect and cause you to lose more length. And in the setting of trying not to overcorrect, sometimes we undercorrect and you still have somewhat of a curve left. So those are really the big risks. It is a surgery, so there's infection, bleeding, anesthesia risk with any surgery. They're not super common. Most patients do pretty well with this. So, but that is something to keep in mind. Another treatment option is plaque, incision, and grafting. And it's sometimes incision, sometimes it's excision. The difference is that sometimes we cut and release the plaque, sometimes we cut out the whole plaque. It just depends on the type of plaque. But in general, that is a procedure that's much, much, much more involved. It involves us raising the nerve off this erectile body and the backside of the erectile body. Sometimes even raising the urethra, which is the channel you pee out of, on the front side of the penis, if necessary. It just depends where the curve is. If it's in the front, you raise that. If it's in the back, you raise the nerves. And then we cut the area of max curves, or let's say your curve is this way, well then we would cut this area where it is and release it so that now your penis has gained that length that was lost back, right? And then and now that we cut it, you have this big gash, or this hole in the erectile body that we have to correct. And the way we correct it is we sew a patch back onto there, and then put the nerves back down, and the urethra back down, and put everything back together, and that should heal up. Now, what is the risk of this? Because there's this hole that develops inside the erectile body. If you don't have erectile dysfunction already, there's a chance that you could develop it. The area where we patch doesn't always stretch quite as well as the rest of the tissue. It can contract. You could get some reversal of the work we did. You can lose penile sensitivity because you have to lift the nerves up and they can get traumatized. You can have your urethral injury. Typically, we identify that during the surgery. We fix it. You may need a temporary catheter. But the two biggest risks, again, nerve injury and erectile dysfunction are there. And then again, you still have your typical surgery risks, infection, bleeding, anesthesia. Sometimes this is done at the same time as a penile implant, which is another treatment option. Now, penile implants can be done by themselves, so you could actually, let's say, again, here's your penile curvature. You have these erectile bodies inside of the penis. We actually can put implants inside of these erectile bodies with a pump down the scrotum, and you can pump up to have an erection, and these cylinders tend to be very rigid, and you can actually mold the penis straight. If you have significant curvature or very dense plaque, sometimes you have to add on a plaque incision. Sometimes in order to try to restore some of that lost length, you may opt to do a plaque incision grafting again, then you would get the risks of both. What are the risks of a penile implant? Well, there's a risk the implant can break at some point. You do become permanently dependent on the implant to have an erection. There's that increased risk of infection because this is a foreign object inside the penis. That risk of infection is typically about 1%, maybe less, maybe a little more, depends on some of your risk factors like diabetes, etc. The biggest takeaway is for men who have normal erections and they don't have any worries about their erectile function, typically these two are the best options. This is a good option for men who have normal erections but have very aggressive Peyronie's disease, very significant curvature. And then a penile implant is an option for men who have erectile dysfunction. In fact, it's the gold standard for men who have erectile dysfunction and penile curvature. And sometimes for men who have lost significant length, you can do a combination of penile implant, plaque incision, and sometimes something called a tunicle expansion, where we make these cuts to expand the rest of the penis to really try to maximize how much length or girth you regain and restore. There is one more option for men who have an indent as the main concern, not so much a curve. Because of the Peyronie's disease, that indent can be embarrassing for some patients and they want to get that restored. And the way we do that is you can do something called an extra tunicle expansion. You can try a vacuum or something like that, but typically you need an extra tunicle grafting is actually what it's called. And in essence, what we do, sometimes we can make micro cuts around there, but really what we do is we just superficially, we don't have to lift the nerves and all that, but we superficially, under the skin, put graft material that'll sort of fill this hole up and mask that area, and that graft oftentimes kind of gets ingrown into the area and becomes part of you. And it hides that defect. It doesn't correct the Peyronie's per se, it doesn't cut out the plaque, but instead it sort of masks it and hides it so that it can be corrected. So that's it on Peyronie's disease. Again, come find us if it's something we can help you with. Talk to your urologist locally, and if there's any questions that we can help you answer, just let us know, leave a comment. All right, until next time.